Hospitals are well prepared for major external incidents and events which can cause a surge in patient numbers. But how prepared are you for internal incidents like fire, gas leaks, utility failure, serious flooding, and non-structural or structural damage which requires the part or full evacuation of a hospital or healthcare facility? In this module, we are going to look at fire incidents and the actions that can be taken to minimize the impact on the day-to-day running of a department. Emergency preparedness is all about anticipating and planning how to overcome any problems that might arise. Let's look at 3 key areas that planning should cover, besides raising of the alarm and evacuation. Continued patient care. As an incident unfolds, how do we ensure ongoing patient care? Communications. How do we keep staff, patients, visitors, and external bodies up to date with essential information, including the seriousness of the situation? Logging of information. Where are patients and staff as the situation progresses? Who is tracking their whereabouts? And is anyone in danger? For example, patients who may remain in a fire compartment close to the fire in a defend-in-place scenario. Let's look at the first of these key areas, continued patient care, in a little more detail. As situations develop, ongoing patient care planning can change significantly. In the early stages of an incident, decisions and actions will be at a ward level. Local evacuation plans must include locations where patients may be taken to that will provide suitable levels of continued care, equipment and staff. Mixing of infectious and immunocompromised patients must be avoided as much as possible within the constraints of the emergency. Patients' notes and clear patient identification is important in clarifying documented resuscitation status or medication regime. The evacuation of intensive care units and theatres is challenging. Clinical staff need to take decisions based on both the fire risk and risk to patients in moving. Equipment that is not available at the new location may also need to be transferred. Outpatient and emergency areas may need to implement plans to divert arriving patients so that they can prepare to accept evacuees. Any local planning needs to consider the hazards contained within a department and any associated risks. Staff need to be familiar with any shutdown or lockdown procedures for equipment, such as MRI scanners, that might create additional risks or prove a danger to firefighters. Remember, fire service personnel are there to fight the fire. They can provide advice, but will not make clinical decisions. Areas receiving evacuated patients must know the number and type of patients to expect so that suitable arrangements can be made. This is where communication is important. Good communications are a vital element in ensuring a safe and organized response to any emergency. Any major incident plan or shelter and evacuation policy needs to cover how staff at the initial incident provide information that ensures everyone is continually updated on progress and the seriousness of any incident. How response teams and the emergency services are contacted. How information on the location and severity of the fire is communicated to the fire service. How key decision makers, like fire officers, safety managers and senior managers, are kept informed, and how they cascade information or decisions to others. Communications information should also contain telephone numbers for alternative support staff who may be able to assist, and direct numbers to emergency services for ongoing communications. Remember, depending on the location or extent of the fire, normal communications like internal telephones may not work. A system of runners, handheld radios, or mobile phones may be required. Any dedicated mobile phones must be pre-programmed with necessary numbers, and staff should be familiar with who to call and when. An emergency fire file or card could contain this information. Logging information and record keeping is vital in ensuring patient and staff well-being. It is essential that the location of patients and staff is tracked for a number of reasons. Knowing where they are may be vital to their safety if the fire spreads. Knowing the location of any patients or staff involved in a defend-in-place procedure and how long they have been there is vitally important. Required medication and patient records can be sent to the correct location. Specialist staff, like anaesthetists, will be able to find their patients quickly. Knowing the number of beds involved will aid ongoing care planning. Anxious parents and relatives can be provided with details of the patient's location. Smoke generated by the fire has the potential to travel between compartments inside buildings if fire compartmentation is not complete. Vertical spread of smoke and flames may also occur externally from broken windows. This may require additional evacuation from affected compartments. Healthcare staff are usually familiar with plans for horizontal and vertical fire evacuation. But if a fire or smoke threat escalates, complete site evacuation may be necessary. How this is done and where patients will be transferred should be the subject of the Major Incident Plan or Shelter and Evacuation Policy. A Major Incident Plan should contain all the elements we have already seen: evacuation, continued patient care, communications, and logging of information. But in addition, any Major Incident Plan should include contact details for identified remote locations for patient care. This might be other hospitals, or safe places of refuge like schools or church halls, in which temporary ongoing patient care can continue while alternative arrangements are made. A temporary clinical triage may be required for the removal of drip feeds, injections, or provision of medication advice. For example, identifying patients who require immediate ongoing care, or those who can be sent home until alternative care can be found. Pharmacies. How will medication be obtained and distributed to patients? What alternatives are available if fire prevents access to the pharmacy? Transport. How and who will transport patients and staff to new locations? Do private ambulance contracts include additional evacuation transport? Security with the aid of police may be needed to lock down the premises to ensure no additional visitors or media gain access to the site. Contact lists of staff who may be able to provide additional help in an emergency should be available. Finally, fire service crews, when they arrive, may well have already downloaded information about the hospital and any significant areas of danger. Information should also be provided in fire service boxes in the reception of healthcare buildings. These should contain full site maps, which will aid attending fire officers to quickly organize firefighting and help navigate the area as fast as possible. This is vital and may save lives in any defend-in-place situation. Plans should detail the locations of the most vulnerable patients, locations of potential gas, chemical and radiation hazards, and the locations of hydrants and risers. Numbering of floors should be consistent with the level in the building, and a common numbering and naming scheme should exist across all departments. It is important that major incident plans consider alternative shelter sites for particularly vulnerable patients. Additional planning will be required for managing patients detained under a Ministry of Justice order or the Mental Health Act, especially those requiring specific security and pharmaceutical measures. These plans may include alternative secure locations, support from local prisons or the police, secure transport and emergency communications with the Ministry of Justice.